Good evening, everyone, and welcome to tonight's topic of tips and tricks for maxillary anesthesia. This is Alan Budens, and my plan for this evening is to speak for about 45 minutes and then to take questions for the remainder of the time that we have this evening. So let's go ahead and get started. For the maxilla, we got two basic types of injections that we can use, our standard infiltrations or block injections. Infiltrations work pretty well throughout the maxillary area and work particularly well using articaine, or the most common commercial name would be septicaine. There's some good evidence, have a little faster onset, seem to get more profound anesthesia, maybe some better duration there as well. But my personal feeling is that the best advantage of using the articaine is that frequently you can give a buccal infiltration and you will not only get buccal soft tissue, pulpal tissue, but also palatal tissue anesthesia. So we don't necessarily have to do as many secondary palatal injections as we might have to do with other anesthetic agents. So that's a really nice advantage to articaine. Now, there's some good evidence out there about the advantages, or are there really advantages, of articaine versus lidocaine and other anesthetics. And this study here that was published in the Journal of the American Dental Association back in May 2011. This was a very well done study, a meta-analysis of 13 well done clinical trials, and they came out with very clear evidence of articaine being superior to lidocaine for infiltration type of injections. But I think it's also very important to note that they also clearly stated that the evidence for any significant difference between lidocaine and articaine for block anesthesia was very weak. There was really no advantage of using articaine for blocks, but a significant advantage for using it for infiltrations. Now here's a little newer study here. This was January 2013 in the Journal of Endodontics. In this study, they found articaine to be 4 times more effective and with greater duration than lidocaine versus articaine in an infiltration injection, and this was with hot teeth. This was with teeth with irreversible pulpitis. So again, some very good evidence that for infiltration, it's definitely an advantageous anesthetic to use. So my basic armamentarium, very simply, 2% lidocaine with 1 to 100,000 epinephrine is still one of my main workhorses for local anesthesia. I use this for most of my block injections, not all of them, but for most of them. I use some bupivacaine plain. This is for the very short duration, single tooth type of restorative procedures, or root planing a deep pocket, anything like that. And also this is my anesthetic of choice for those few patients that I really can't use a vasoconstrictor on. I really don't feel their cardiovascular stability is sufficient to take the risk of using even the very small amounts of epinephrine and other vasoconstrictors that we use in dentistry. 4% articaine with 1 to 200,000 epi is virtually the only anesthetic I use for infiltrations, and it works very, very nicely on both the maxilla and the mandible. We'll talk a little more about that later on. And I also use it to anesthetize some of these hard to get numb, hard to keep numb patients. And so patients that fall into that category, patients with a history of drug abuse, patients that drink a lot of coffee, heavy smokers, patients that take a lot of over-the-counter or prescription medications. Lots of times we find these patients difficult to get numb and or to keep numb. And anecdotally, I admit, we find that the 4% solutions, articaine or prilocaine, tend to work better on these patients. I prefer the articaine personally. Now I also have some long-acting bupivacaine handy for maintaining pain control postoperatively for patients or for long duration procedures. And I'll talk a little more about that as we go along as well. And then you'll see down at the bottom, I also like the newer onset buffering agent. Really speeds up the onset of your anesthesia, basically cuts it down to about 1 minute to 2 minutes after you give your injection. The patient is numb and you're ready to go. and it's also a more comfortable injection for the patient because it buffers the acidity of the local anesthetic. And then I like having a little bit of the Oraverse anesthetic reversal agent handy for those patients who just really hate that feeling of being numb, and they're going, hey, doc, is there something you can do, something you can give me to get this numbness to go away faster? So I think that's a real nice agent to have handy there. You know, both these agents are relatively expensive, but I'll tell you, for what the cost is versus the ease and the success that I have with anesthesia, and also for the patient benefits that these offer, I think it's money very well spent. There's nothing like having happy patients. Those happy patients will refer more people to you. It'll pay for itself in the long run through giving your patients the best possible care you can. Okay, so back to our infiltrations. Advantages of infiltration, certainly very easy to do. They're pretty safe because we're generally injecting into areas with no major big blood vessels or anything that we're likely to have problems with. We get much more rapid onset, and if we are dealing in a surgical situation, we can use it for hemostasis, an anesthetic agent with a vasoconstrictor, to control the bleeding in that local area. But disadvantages, if we're working on multiple teeth, we have to give multiple injections generally, and the duration is shorter. It's about half the duration of what we would get with a block type of injection. So here's a graph. This is for infiltration injections. You'll notice the time scale on the left there goes up to 70 minutes. And we can see in the center here the big four anesthetics. We've got lidocaine, bupivacaine, prilocaine, and articaine. All of these are pretty equal. Given as an infiltration, they'll give us about 60 minutes of pulpal anesthesia. And I want to stress this is pulpal anesthesia. Soft tissue anesthesia will be longer. But for pulpal anesthesia, about an hour. This is going to be plus or minus. Think of it as being a bell-shaped curve. Some people it's going to last a little longer, some people not quite as long. But good, reliable anesthetics there. Now I want you to notice over on the right side here, this is bupivacaine, Marcaine, our long-acting anesthetic. And notice that as an infiltration, its duration of pulpal anesthesia is less than our other anesthetics. Now, I'm talking about pulpal. Keep that in mind. It's less than the other anesthetics. Over on the far left, we can see plain anesthetics, plain lidocaine, plain prilocaine, very short pulpal anesthesia, 5 to 10 minutes at best. Now, plain lidocaine is no longer available in the dental market in a dental cartridge, so don't worry, no, that's not available to us. We could use a multi-dose vial from a medical supply, but I can't imagine why you would want to do that because there's no real advantage to plain lidocaine. And then last, here is our mepivacaine. Plain mepivacaine delivered as an infiltration will give us about a half an hour plus or minus of pulpal anesthesia. So like I say, that's very good for doing short duration, single tooth type of invasive procedures, doing a restoration and so forth. All right, now we're comparing the two graphs here. Over on the right side we have for block injections, and I want you to notice that the time scale is considerably different here. We're going up to 300 minutes. Here for our big four, lidocaine, mepivacaine, articaine, prilocaine, all of these will give us now about an hour and a half to 2 hours of pulpal anesthesia when delivered as a block injection. And then if we look at the far right, here's our bupivacaine, our long-acting anesthetic. Now delivered as a block, we have a significantly greater duration of pulpal anesthesia. So where I specifically like to use bupivacaine in this example here is if I'm doing a large reconstructive case and I'm going to have that patient in the office for 3-4 hours or so to prep numerous teeth. It's really nice to give my initial injection, or however many injections I need, with lidocaine or with articaine to get the patient numb in a quick fashion. And then at any point, as long as the patient's still numb, I can chase that original injection with a block of bupivacaine and have pulpal anesthesia for a good 4 hours, if not more. which makes it very easy to do these long procedures without having to keep stepping back and giving additional anesthesia, taking off rubber dams or whatever it is we need to deal with there. Just makes it a lot simpler for me, and it's nicer for the patients because I don't have to give them as many injections, and they're always happy about not getting stuck with the needles any more frequently than they have to. So that's a good way to deliver your bupivacaine to get the long pulpal anesthesia. Now you'll also notice down here at the end, on the left end, the plain prilocaine given as a block. Now our pulpal duration of anesthesia has boosted up to about 50, maybe 60 minutes of pulpal anesthesia. So as an infiltration, prilocaine plain was good for maybe 10 minutes. Now as a block, it's good for maybe an hour. So a significant difference in the manner in which we deliver that and the success with which we'll have. And you'll also notice that the bupivacaine plain has also boosted up a little bit here, maybe 45 minutes or so of pulpal anesthesia. Okay, so when we look at the overall duration of anesthesia, and we're talking pulpal anesthesia in this sense here, dependent largely upon the chemical characteristics of the anesthetic agent. The overall concentration, in terms of duration, diffusion away from the nerve site, and then the lipid solubility is a huge, very important factor, and also the protein binding to receptor sites. Also a factor is dependent upon the technique that we use. And you'll notice that up to this point, really, the duration of anesthesia and the onset of anesthesia are identical, except in this one point here. For duration, it's diffusion away from the nerve itself. For onset, it's diffusion to the nerve. Since we never know quite how close we're dropping that anesthetic to the nerve, we always hope we're close, right? But ideally, we're trying not to actually hit the nerve. Then we know exactly where it is, and we know we've got the bullseye, but the patient jumps, and we don't like doing that to patients. So duration and onset are the same up to that point. Now, the one other thing that really is important for duration of anesthesia is the presence of a vasoconstrictor in that anesthetic agent. But I want to stress that the concentration of that vasoconstrictor is not really important. For example, we have lidocaine available with 1 to 50,000 or 1 to 100,000 epinephrine here in the United States. I personally prefer to use the 1 to 100,000 for anesthesia because if I should accidentally inject that into a blood vessel, it has much less likelihood of causing any cardiovascular side effect of significance. Now, with most healthy patients, even if we did inject that into a blood vessel, it would probably not have much of an effect. But the truth is, we are dealing with more medically complex patients. So we want to be careful and try not to get into a blood vessel. So I prefer to have a little better safety margin, use the lower concentration of epinephrine in the local anesthetic. The difference in duration between 1 to 50,000 lidocaine and 1 to 100,000 lidocaine, that duration difference is maybe a handful of minutes at the most. So it's not really significant. Where I do use 1 to 50,000 epinephrine and lidocaine is for localized infiltration to control bleeding, for hemostasis in surgical cases. And you may have noticed in my armamentarium, I also had articaine. Articaine is available, septicaine is available with 1 to 100,000 or 1 to 200,000 epinephrine. I prefer the 1 to 200,000 epinephrine again because it gives me just a little more safety margin. And I just like to keep things as safe as I possibly can. Okay, so let's switch gears here over to a little bit about some block injections for the maxilla. Just a quick anatomy review, if I may, here. We'll start out here looking at this lateral view of the skull. And what we have is the maxillary division of the trigeminal nerve comes out of the middle cranial fossa through the foramen rotundum, and it will traverse across this little space here, which is the pterygopalatine fossa. And then it goes forward through the inferior orbital fissure and changes its name now to the infraorbital nerve, which goes across the floor of the orbit and then emerges out onto the midface area as the cutaneous infraorbital nerve. Now notice that as it goes across the floor of the orbit, it gives off a little branch here at the front. This is the anterior superior alveolar nerve, which drops down and innervates the incisor teeth. A little bit further back, it gives off the middle superior alveolar nerve, which drops down and innervates the bicuspids and maybe a little bit of the first molar. Now back here posteriorly within the pterygopalatine fossa, the posterior superior alveolar nerve came out and comes in through little foramina in the tuberosity of the maxilla to get to the molar teeth to deliver sensory innervation to the pulps of those teeth. Now also coming out of this pterygopalatine fossa and medially going deep into the back of the nasal cavity, we have nasopalatine nerve branches which traverse across the septum of the nose and then emerge out onto the hard palate just inside of the central incisors and deliver sensory innervation to the mucosa of the anterior hard palate and very common accessory innervation to those anterior pulps of the teeth there. And then posteriorly we have the greater palatine nerve. This comes out of the foramen, which is usually back in the third molar area, just a few millimeters in front of the posterior edge of the hard palate. This greater palatine nerve comes forward, sensory innervation to all the mucosa of the hard palate, and again a very common accessory innervation to the molar and bicuspid teeth of the maxilla. So this evening I'm not going to talk about all the blocks. There's nothing new I can tell you about a posterior superior alveolar nasopalatine or a greater palatine nerve block. So I want to just talk quickly about a little bit of the anterior maxilla and some different ways we can get anesthesia up there. And then one of my all-time favorites is I want to talk to you about a complete maxillary division block. Okay, so for the anterior, the standard technique that we're usually taught in dental school is the infraorbital approach, which is we're going to try to get the needle up near this infraorbital foramen, and hopefully the anesthetic will work back and get the anterior and middle superior alveolar nerves to anesthetize these anterior teeth for us. That's our aim with this injection technique. So we're going to deliver the anesthetic at the infraorbital foramen, which is just below the rim of the orbit. And the way to find that foramen is we want to palpate the inferior border of the mandible. And you want to feel for the low spot of the rim of the orbit. It's usually a little bit closer to the side of the nose than really right in the middle. But you feel for that low spot, and then I'm going to drop my finger down, using my index finger here. I'm going to drop my finger down about a centimeter below the inferior rim of the orbit, and I should be right over that foramen. And you can usually feel a little bit of a dent there, and if you try this on yourself, if you press firmly, you might even get a little tingling there. You might get a little Tinel sign when you press on that spot. Now I'm going to keep my index finger there. I'm right-handed with my syringe, so this is my left hand. My index finger over the foramen. Now I'm going to take my thumb, and I'm going to hook my thumb up into the vestibule, get all the way up to the top of the anterior vestibule there, so that the distance that I'm going to stick the needle in, penetrate into the tissue with the needle, is only going to be the distance between my two fingertips there. I'm going to be directing the needle up parallel with the anterior slope of the maxilla. Now our depth of penetration is going to vary depending upon the height of the vestibule and the length of the patient's face. I like using a 30 gauge short needle for this. I'm going to drop a modest volume of anesthetic here, a third to half a cartridge, and the patient comfort level is moderate to high. The anterior approach, which here we're coming over the cuspid tooth, this is moderately comfortable. If you go a little more posteriorly and direct your needle up over the bicuspids, it's more comfortable for the patient because this is not quite as sensitive posteriorly as it is anteriorly here. We're very, very sensitive in this anterior area. And here, looking at a couple of skulls, here's the anterior approach and perhaps a little bit longer pathway through tissue as well. The more vertical approach over the bicuspids is a little bit more awkward, but I find it much more comfortable for patients, so I prefer using that. Now, one thing I want to note here is that you do not need to get the needle tip into the foramen when you're doing this injection. I know a lot of people are afraid of giving this injection because they're afraid they're going to do this right here and stick the needle up into the orbit and skewer the eyeball. No, 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 no. This is not going to happen. Number one, I keep my finger over this foramen. As the needle comes in the tissue here, I can feel the needle in the tissue underneath my fingertip. As soon as I feel it there, I stop, aspirate, go ahead and drop my bolus of anesthetic, take the needle out, and then with my fingertip, I massage this area to work the bolus of anesthetic down into the foramen and back to get the anterior and the middle superior alveolar nerves where they branch off within the floor of the orbit. And also by keeping that finger there, there's no way my needle is going to go high over the inferior rim of the orbit and get into the eyeball. So, you know, it's a very safe injection, very simple and easy to do. Okay, but there is a but here. This doesn't always work, particularly for getting the bicuspid teeth, because as you can see in a fair number of patients, they don't actually have a middle superior alveolar nerve coming down to the bicuspid teeth. In this situation, usually the innervation to the bicuspids is coming from the posterior. So this injection won't work to get the bicuspid teeth. We'll only get the anteriors using this approach. So it's a little bit of a limited success there. And also you may note that it won't give us palatal soft tissue anesthesia, and we may still have some accessory innervation coming to the pulps from the nasopalatine nerve here on the midline. So there's a couple of alternative approaches to this anterior area, and one of them is called the palatal approach to the anterior and middle superior alveolar nerve. And what this is, we take the midline of the palate, the mid-palatine suture, and we're going to drop a perpendicular line that's going to bisect the two bicuspids. If they've been to the orthodontist and they only have one bicuspid, we'll bisect the one bicuspid. And then we're going to go about halfway out on that line between the free-gingival margin of the bicuspids and the midline of the palate, and that's where we're going to give our injection. Now, the simple way to think of this is that it's basically at the junction between the more horizontal hard palate and the more vertical alveolar process. That's basically your injection site, which should be a little bit above the apices of these bicuspid teeth. So our depth of penetration, because this is a palatal injection, is going to be very minimal, easing it into the tissue. I use a 30 gauge short needle, and I inject a very small amount of articaine. I like using articaine for this block. And I inject maybe a stopper, 2 stoppers worth of anesthetic, very, very slowly, easing it into the tissue, so I can make this a fairly comfortable injection for the patient. All right, now I know you're thinking palatal injection, why on earth would I want to be doing this? What are the advantages? Well, first off, this gives us palatal anesthesia, buccal tissue anesthesia, and pulpal anesthesia all at once. However, we don't get the lip or the mid-face area. With our conventional infraorbital approach, we get the lower eyelid, the side of the nose, and the upper lip. This maintains the lip with normal sensation, which is great if you're doing cosmetic work, doing veneers, anything like that where you want to maintain a smile line. And also, patients recover from anesthesia faster. They can go back to work. They don't have that numb lip sensation and so forth. Also, this is much more reliable for getting anesthesia of the pulps of the bicuspid teeth as well. So this really very simple injection onto the palate gives us actually better anesthesia than conventional infraorbital approach. Of course, there are always a couple of disadvantages. The duration is not quite as long. It's not a true block. It's sort of in between an infiltration and a block injection. But I find that using articaine, I do get plenty adequate duration, and that works very nicely. But probably the biggest disadvantage is, oh, it's a palatal injection. Oh, I hate giving palatal injections. Well, no, you shouldn't hate giving palatal injections. Number one, it's better to give than to receive, but number two is that if you can give comfortable palatal injections to your patients, that is a huge practice builder. So if you don't know how, learn how. It's important to know how to give good palatal injections. So here's what I do for palatal injections. Number one, I'm a big believer in topical anesthetic. I dry the tissue off, place topical anesthetic on there for a good minute and a half, 2 minutes. Let it to penetrate into the into the tissue there to get just a little numbness on the superficial tissue. And I keep the swab of topical anesthetic on there when I'm ready to inject. I put the needle in just off the side of the Q-tip so that I'm using pressure as a distractor as I'm putting the needle in. And then I inject the anesthetic. I'm using small volume, but I inject it very, very slowly, just easing it, teasing it, if you will, into the tissue. Now, sometimes with really sensitive or phobic patients, I'll give a buccal infiltration with articaine first before I do the palatal injection, but I don't really need to do that all that often. But this last item down here, number 5, is, I think, the most important. I tell patients everything that I'm going to do to make this injection comfortable for them. So I tell them I'm going to put topical anesthetic on there so they won't feel the stick of the needle as much. And I tell them that I'm going to push on their palate so they won't feel the stick of the needle as much. And then when I put the needle in, I tell them you're going to feel a little stick. If they do, I already told them, not a big deal. If they don't feel the stick, great, I'm looking good. And then I start pushing the anesthetic in. I tell them you're going to start to feel some pressure here. Shouldn't hurt at all, but you're going to feel a little pressure. So I'm explaining everything to them, and I think this is really important because when patients feel something they didn't expect, when they are surprised while you're giving an injection, that's when they'll start to jump or get fidgety, complain. So I like to take that element of surprise out, tell them everything that I'm going to do. If they feel anything, it's okay because I told them they would feel something. But if they don't feel anything, I look even better. So that's my approach to palatal injections. All right. Now, one more way we can get anterior teeth anesthetized is called the palatal anterior superior alveolar nerve injection. And in this technique, what we're going to do is we're going to inject back here over the nasopalatine foramen or incisive foramen, if you will. And what this does is it anesthetizes the palatal gingiva from cuspid to cuspid. We get the pulps of all 6 anterior teeth from cuspid to cuspid, and we get the buccal gingiva from cuspid to cuspid with a single little palatal injection here. So here, what I do is I'm coming in, I don't come in right over the incisive papilla, but you can see the papilla right there. I come in where the arrow tip is here, just a little bit off to the side. Because the tissue is less fibrous there, the needle will penetrate in easier and be more comfortable for the patient. So I slip the needle in there, and then I start to straighten the needle up a little bit to get a more vertical orientation so that I get the tip of the needle into the foramen. Now, I don't need to get very far into the foramen here, just enough to know that I am into it. And then I drop about a quarter cartridge of articaine, very slowly easing that into the tissue. And that will block the nasopalatine nerve here, also work up the canal and get to the apices of these teeth here and give me the buccal anesthesia as well. So it's really kind of a combination of a block injection and a infiltration injection, if you will. And this is the advantage of using the articaine for this technique. So this is a nice slick trick to get the anterior area anesthetized. And again, it doesn't anesthetize the lip, so it maintains smile line and so forth for patient comfort and for assessing their smile line. Okay, now my favorite, well, one of my favorites, I have many favorites, is the complete maxillary division nerve block. This is a technique that we're going to use to get all the pulps of the teeth, all the buccal tissue, all the palatal tissue, all the mid-face region. We're going to get the whole quadrant anesthetized, maybe a little fuzzy at the midline. But what we're going to do here, 2 injections to achieve this, 1 cartridge of anesthetic, and here in the United States we're talking about a 1.8 cc cartridge. I know in some countries they use different sizes, just to make that clear. We have 2 approaches that we can use here. One is the posterior superior alveolar approach, which is a more lateral approach, and the other is the greater palatine canal approach, which is on the palatal side, the medial side, for that approach. Okay, so again, just a little quick anatomy review here. We mentioned that the maxillary division of the trigeminal nerve is coming out of the foramen rotundum and traversing across the roof of this pterygopalatine fossa. So we've got the whole root of the nerve right there. Also, we have this little ganglion here, the pterygopalatine ganglion, which is a secretomotor relay station for all the mucus glands of the hard and soft palate, of the nasal cavity, and also for the lacrimal gland up in the upper corner of the eye. And then finally, we also have terminating into this pterygopalatine fossa the maxillary artery. All of its end branches are going into that little fossa and then being distributed out with the terminal branches of the maxillary division of the trigeminal nerve. So, with the complete maxillary division block, using the lateral approach, the posterior superior alveolar approach, essentially it's the same technique that we use to do a conventional posterior superior alveolar block to approach the foramina on the posterior of the maxillary tuberosity. The only difference here is that we're going to go about twice as high, twice as deep. We're going to angle up and back in more distinctly above the maxillary tuberosity. Now, one thing you're probably thinking of is, ooh, I know that the posterior superior alveolar injection has a fairly high risk of hematoma. Yes, it does, and using this lateral PSA approach has an even higher risk of a possible hematoma. You can see right here on this dissection picture here on the right side, we can see this little clump of blood vessels right here are the vessels going into the foramina of the posterior superior alveolar nerve canals. And if we're going to take that needle up higher into this area, here's all these terminal branches of the maxillary artery. And by the way, this dissection is only illustrating arteries. It doesn't show any veins. So this is a very rich vascular area, and because of the high risk of hematoma, this is not a technique that I teach or that we teach at the dental school or most schools teach. What we prefer is to use the other approach, the greater palatine canal approach. The greater palatine nerve branches off the maxillary division, descends down in a little bony canal down to the hard palate where it emerges out of the greater palatine foramen and then goes forward on the hard palate. So what we're going to do in this technique is we're going to enter that foramen and insert our needle up into this canal. Now, let me tell you right off the bat, we don't need to take the needle all the way up to the base of the skull. Tempting as that may be, you don't really need to. This is a bony canal here. If we inject our anesthetic into the canal, it's going to go up the canal. It has no space to come back out to the palate, so it's going to flow up the canal, and it works very nicely. All right, so let me walk you through this technique here. First off, we need to figure out where the greater palatine foramen is. So we can see on this skull here that it's right opposite about the middle of the third molar. It's distinctly distal to the second molar. What I do is I put my finger in against the palate and I just run my finger back between the more vertical alveolar process and the more horizontal hard palate. And as you go back posteriorly, the tissue gets a little spongier here. Just before you go back onto the soft palate, and you know the soft palate because the patient starts gagging, but just before you get back there, you'll feel a little spongy area right here. Your fingertip will fit right into an indentation. Your finger is right in this little bony funnel, which funnels down to the actual opening of the foramen itself. So I locate that foramen there. I put topical anesthetic on, and then I give a palatal injection just off the edge of the Q-tip there. Now I know in this picture it looks like I'm way forward with this Q-tip, but you'll notice that this line back here, this is the separation between soft palate and hard palate. You can tell this is soft palate because it's redder. It's more vascular than the denser tissue of the hard palate. So I'm just in front of there. I'm going to give my injection there to give a greater palatine block. I'm going to wait about 2 minutes, and then I'm going to come back in, repalpate to make sure I know where that foramen is, Make sure I can feel that there. And now I'm going to come in, with a 27 gauge long needle, and I'll either deflect the needle with my fingertip, or I can put a permanent bend in the needle. And most people that like bending the needle for this, they'll put about a 45-degree angle onto that needle. And now I will penetrate through the tissue over the foramen, single penetration, and then gently alter the angulation of the needle until I feel it drop into the foramen. And if I can't get it to drop into the foramen, I will take it out, I'll repalpate. Usually my mistake is I'm too far anterior to the foramen, so I'll go back just a little bit more posterior, and I usually get it to drop in on the second try there. Once I feel it drop into the foramen, I passively insert the needle up into the canal. If there's any resistance, stop. Don't force it at all. And I don't go very far up the canal. I just ease it into the canal. I can see the needle disappearing a little bit up into the palate, so I know it's in the canal. So the depth of penetration is really going to vary. As I say, as long as you're in the canal, it's going to work. I go ahead and drop the rest of that full cartridge of anesthetic. This is with the patient lying down, and I leave the patient lying down. So the anesthetic will flow up the canal and give me my anesthesia. Now, one thing about this injection is that your patients are going to be impressed for two really nice reasons. Number one, they are going to report that they have never felt as numb on the upper arch as what this injection will do. It's good, profound anesthesia, soft tissue and pulpal. The other thing is patients are going to be very impressed because you accomplished all that with only 2 little injections, and they only barely felt that first one, that little injection over the greater palatine canal. So you look really good and your patient's really numb. You can do this full quadrant of dental work. It's very nice. Now, is there a disadvantage? Yes, there is. With either approach, doesn't matter, there is a small percentage of times when we drop the anesthetic and get it into this pterygopalatine fossa and it flows up over the maxillary division of the trigeminal, every once in a while it will flow back posteriorly, and when it does that, it may get this little branch right here called the zygomatic branch. This is largely cutaneous, but it does have a little communicating branch that takes the secretomotor innervation up to the lacrimal gland of the eye. So I always tell patients when I do this, if you feel that your eye is getting dry, let me know. I'll either put some moist gauze over their eye or I can drop in some eye drops. I tell them, let me know if it's getting dry. It happens occasionally, but I don't want to risk you potentially scratching your cornea if you get a dry eye. This usually doesn't last very long if it happens, and I'd say it happens less than 5% of the time when I do this block. So it's not a big concern. Okay. Now, a little troubleshooting here. Hot teeth. Oh, man. Our, least favorite thing to deal with that infected tooth. As we know, we want to give a block as far away from that injection site so that our anesthetic will properly dissociate and give us good quality anesthesia. And, we don't really want to inject into that localized site anyway because we don't want to risk spreading the infection and making it worse. Okay. Now, this data here is from mandibular type of blocks. But I think it's worth noting here, talking about the different techniques that we can use, the different blocks, or you can see down here using buccal and lingual infiltrations. And what's important here, and the reason I put this in, is that it points out that no technique was fully acceptable by itself. So when we're dealing with hot teeth, I want you to appreciate that you want to give a block, but don't expect your block to work. It might work a little better than half the time on the maxilla, but we're lots of times going to need to use a secondary technique. That's the point that I'm trying to make here. So secondary techniques. In the past, what we've used are periodontal ligament injections or intraosseous injections. Certainly the PDL injections are very easy to give. There are some disadvantages. The intraosseous is a little more reliable, a little more durable. But let's just quickly look at these here. First off, periodontal ligament injection. I want you to notice that in both these diagrams, your anesthetic is not flowing down the periodontal ligament space. It's actually going into the bone around the teeth, which means that this is technically an intravascular injection. It's going into the trabecular blood spaces of the bone itself. So when we do these, for a bicuspid or an anterior, I'll do both buccal and lingual sides. For a molar, I'll give an injection at all four corners of the tooth here. Duration's a little bit unpredictable, usually about 15 minutes. The big thing I don't like about these is I've had a lot of patients report that that area where I gave a PDL injection was sore for 2-3 days after the appointment, and that they were uncomfortable about that because I think we injured the periodontal ligament. We're using a very small volume of anesthetic with these injections. Now, all the manufacturers that create these type of intraligamentary delivery devices, they all recommend that you only use plain anesthetics. The reason being, again, because we're injecting into a highly vascular space. Now, we're injecting such small volumes, we're not likely to cause any significant problem, but if you have a patient who is at some risk in terms of their cardiovascular stability, you definitely don't want to inject a vasoconstrictor using this technique. So be careful about that. Think carefully about what you're doing. Now, a couple of other things about the periodontal ligament injection. You need to be careful not to use too much force because you can damage the bone, you can damage the root of the teeth there, so don't use too much force. The other thing is if you're working with children, it's recommended not to inject around primary teeth or too close to the mixed dentition because we might injure a developing tooth bud underneath the baby tooth there. So be careful about that. And then the last thing is simply that this is the only injection, it's the only dental injection where it's recommended that we prophylax the patient for the injection. The reason being is that we're going into that periodontal pocket. There's a lot of pocket bacteria. We're going to push some of those into the tissue, so it's recommended we prophylax the patients who are at high risk before we do this type of injection. All right, now the intraosseous injection is where we're going to use a little perforator to penetrate through the cortical bone between two neighboring teeth, and then we're going to come back and inject anesthesia through that hole into the site. So the first thing we want to do is to assess with a radiograph, do we have room to get in between those teeth? As you can see here, we don't have much room between 18 and 19 on these radiographs. Here, between 18 and 19. So I would not want to try to do an intraosseous injection there. But I could use this space between 19 and 20 to get number 19, or for 18 I could use the space back here between 17 and 18 with an intraosseous technique. And then you also want to make sure there's no infection, no periodontal vertical defect or anything back in that area that is going to be a complication. We give the intraosseous injection about 2 millimeters below the free gingival margin of the two neighboring teeth, and you want to make sure that you're going through attached gingiva. We'll give a little infiltration over our injection site, then we'll go ahead with the perforator and make the little hole there. And notice on this patient, we're just barely in attached gingiva. But you want to be in attached gingiva because this is a slowly rotating handpiece here. You don't want to risk grabbing the free gingival tissue and tearing it there. So you make a hole through the tissue. You'll feel the perforator penetrate through and drop through into the cortical space. Then you take that out. Now you come back with your needle. You need to find that hole at just the right angle and insert the needle through. Now you can inject your anesthetic into the bone there. And you want to watch for backflow. If you're seeing backflow, it means you're maybe not in the hole or your hole's not all the way through the cortical bone. But this is a good, reliable technique for getting pulpal anesthesia. Gives a little better duration, 15 to 30 minutes, better duration than a PDL, and we can go back and do a second injection through that hole there. Again, we're using a very small volume of anesthetic. We get the pulps of the two teeth on either side. No lip anesthesia, it's only getting those two teeth there. And again, recommended to only use a plain anesthetic here. All right, but what you'll see more of now, and this is reflected in the endodontic literature, I've cited a couple of endodontic articles here, is that instead of using a PDL or an intraosseous injection on these hot teeth, for secondary injections, they're using articaine delivered in both a buccal and or a lingual or a palatal infiltration, and they're getting very good backup anesthesia to their original block with this technique. Now here's a study. This was done on the mandible, but my thinking is that if it works for the mandible, it's going to work even better for the maxilla. So this was Robertson and his group. This was back in 2007, published in JADA. And what they did is they did buccal infiltrations from second molar to first premolar. And with lidocaine, 45% of the time they had pulpal anesthesia of the second molar, and up to 67% of the time they had pulpal anesthesia of the first bicuspid. But when they did those same buccal infiltrations with articaine, 75% success with the second molar, up to 92% success with the first bicuspid. So significantly better anesthesia using the articaine, significantly better success. And it also was faster onset with articaine, 6 to 11 minutes with lidocaine, about 5 minutes with articaine. And again, I stress that a big advantage with articaine is that lots of times if we give a buccal injection, we also get the lingual or palatal anesthesia as well. So we may not need to do that second injection. But personally, I'll say, and this is more pertinent for the mandible, if I'm working in a mandible, on a hot tooth on the mandible, I like to give both the buccal and the lingual infiltration. You can see the lingual infiltration with that thin lingual plate of bone in the molar area. We're going to get more rapid onset, and we're going to get more profound anesthesia dropping that lingual infiltration there. Okay, so there's no contraindication for mixing our anesthetics any way we want. I will, for example, give the block with lidocaine and then give the infiltrations with articaine. And actually, if you're thinking about hot teeth, plain anesthetics will actually work better in an infection site. They'll dissociate better, but they're vasodilators, so they will wash out into the bloodstream faster, so they won't give you much duration there. Now, I know a good number of people like to use plain anesthetics as a pre-injection because the plain anesthetics are less acidic than the vasoconstrictor-containing anesthetics. The reason the vasoconstrictor anesthetics are more acidic is to give the shelf life, the stability of the product to maintain shelf life. But the plain anesthetics have less of a burning sensation. So a lot of people like using that as a initial injection, and there's nothing wrong with doing that. Just be aware that if you do come back with your second injection using a vasoconstrictor, you may initially get a little more cardiovascular side effect because your plain anesthetic was a local vasodilator where you're giving that injection. Again, no contraindication to combining these amide anesthetics. The only thing is to keep in mind that they are additive in terms of dosage, so you don't want to exceed the maximum safe dosage for the agent of the highest concentration. So just real quickly here to get into our final phase here, looking at dosage here. Roughly we have 18 milligrams of anesthetic per percent of our concentration. So 2 times 1836, 4 times 1872. These are not exact numbers. These are approximate of how much anesthetic is per cartridge, but they're pretty close to the ballpark there, so good working numbers. And in terms of what the FDA maximum dosage recommendation is per pound, we can see lidocaine and articaine are identical. Bupivacaine plain or with vasoconstrictor, 3 milligrams, 4 for prilocaine. Notice that bupivacaine and prilocaine do have definite limits. You'll reach this limit with a 135-pound patient for bupivacaine. You'll reach the limit of prilocaine at a 150-pound patient. But with lidocaine and articaine, there is no limit there. So what does this mean? Okay, if we take 2% lidocaine with 1 to 100,000 epinephrine, 150-pound patient, 3.2 milligrams per pound, we can inject 480 milligrams. Divide that by 36 in a 2% cartridge, we can inject 13 1/3 cartridges. Wow. Now, none of us are going to do that, I don't think. You know, usually I'm using 1 to 2, maybe 3 cartridges for most of the dental procedures I do. But what this means is that lidocaine gives us a huge safety margin. a big, big, big safety margin, which is why I like it. Now, if we use articaine, same numbers that we see, but if we use the actual number of how much is in a cartridge, 68 milligrams, that limits us now to 7 cartridges. It's about half of what we can use with lidocaine. And where this really becomes important is if we start combining our anesthetics. If we combine lidocaine and prilocaine, or if we combine lidocaine and articaine, it's the 4% solutions that limit how much we can give. And for example, if I'm going to do a procedure, I'm thinking of 4 quadrants, 4 wisdom teeth, and I might drop easily 2 cartridges per quadrant. That's 8 cartridges. If I'm using a mixture of lidocaine and articaine together, I've already exceeded the maximum safe dosage for that patient. And, you know, I don't really want to get anywhere near that maximum safe dosage, let alone risk exceeding it. So you just want to be careful about what you're doing, how much you're using. So again, just to summarize, for most of my block injections, I prefer to use lidocaine. For all my infiltrations, I use articaine. And for some of my blocks, like I talked about with the anterior maxilla, I do like using articaine for those blocks there because I know I'm only going to use small amounts of anesthetic, 1 or 2 cartridges usually at the most, so there's no risk factor there. So to wrap up here, what defines success with anesthesia? I like this definition here. This is my working definition. Adequate anesthesia to ensure patient comfort for the duration of the procedure, which means it really depends on how invasive the procedure is going to be, how long I'm going to be in there, and it depends on the patient. How sensitive, how phobic, whatever is the patient is an important factor as well. So we come in with our primary idea of what anesthetic should work, and we need to have backups. The hammer will work, but I don't recommend that as being a good backup. So you need to think carefully about what you can do. So whether you're going to use an infiltration or a block, it's really dependent upon what we're trying to do, the patient themselves. What's our comfort zone in terms of the techniques and so forth? Do we know the proper technique? Hopefully a better technique than this gentleman's using on his patient there. And then selecting the right anesthetic agent. It's important to understand that our anesthetic agents are not one thing does everything well. We have different agents for different reasons. Let's use them wisely. Okay, so it's the thought that counts. Think about the process here. In order to have patients that open up wide like this, and believe me, I wish all of my patients could open like this, but if they're afraid that you're going to hurt them, they don't open very wide. So if you can deliver good, comfortable injections, you can gain patient trust. They will relax, they'll start opening wider, make it easier for you to do your dentistry, and they'll refer more patients to you. So everybody wins, everybody succeeds. So that's it for the program here. I'm going to take some questions here, but let me just point out my email address there. If I don't answer your question tonight, or if at any time you have questions, please email me. I'm always happy to answer questions, and I will send you back an answer just as quickly as possible.